শুরু করতে পারি। আসসালামু আলাইকুম। Good evening. Welcome to today's IPDI virtual classroom. We are eagerly waiting today's topic. ETT is a common thing, but as already discussed, it is not good written in our textbook. So Dr. Monwarul, A.K. Monwarul Islam, my younger brother, everybody known is a versatile and good academician, researcher also. He also part of IPDI. Welcome to this session. I'm requesting Professor Abdul sir, lots of panelists here, lots of faculty today. All are our respected teacher, Professor Iqim Reza, Professor Saiful Islam, Abdullah Jamil, Dr. Kaisan Rasulullah Khan, also different parts of Bangladesh. We are really grateful to the IPDI, to the panelists and faculties, and also Dr. Monwarul. For this, sir, please open the session.
Good evening, everybody. And as Mohsin was saying, we are eagerly awaiting for Monwarul's intake on ETT. This is very important because among the non-invasive tests, ETT is something that really gives you some information about the functional status of the patient, the possibility of future event, and what sort of intervention the patient actually need or do not need. To decide on that, ETT is really helpful. And most of all, we have to know when to do it, how to interpret it, and for whom it is imperative, for whom it is at all not necessary. And all these things, I think, will be very much clarified after Dr. A.K. Monwarul Islam lecture. He is, as you know, is an academic genius. He loves to learn, he loves to teach. Today, we are going to have another beautiful lecture from him. Thank you, Dr. Monwarul.
I'm requesting everyone, please mute your Zoom apps because we are waiting our excellent lecture, Dr. Monwarul. Dr. Monwarul, please share your screen and start your session.
Thank you, sir. Thank you all. I'm delighted that I have got a chance to say something before such a august gathering. This topic is actually very important, and what I feel since my studentship that this topic is to some extent neglected and not even the good teachers did not feel comfort while going to teach this topic. So I have some interest on this issue. Exercise tolerance test. This is one of the, I think, bread and butter for the cardiologists, even in 2021. There are some synonyms regarding ETT. As, for example, in India, the most well-known nomenclature is TMT, treadmill test. The basic concept is that this is a cardiovascular stress test that utilizes treadmill or bicycle exercise with ECG and blood pressure monitoring. Sometimes it is called exercise ECG test, exercise stress test, and stress ECG test. So there are a lot of nomenclatures regarding this ETT. What is the importance of ETT? The most important aspect that it is a non-invasive test and it is relatively cheap test. If we compare it with the counterparts, as the main purpose of ETT is to diagnose coronary artery disease. And as we already know that there are a number of invasive and non-invasive tests available to diagnose coronary artery disease in an individual patient. And it starts from confirmatory tests like cardiac catheterization, that is coronary angiography, to ETT. And in between two, there are a number of other tests like stress echo and also stress SPECT, which is based on the nuclear imaging. If we compare these 4 tests, ETT probably ranks a bit lower, but we should mind that this is non-invasive. It does not need any radiation, and also it has got reasonable sensitivity and specificity for diagnosis of coronary artery disease. Who should have ETT? The basic principle for each test that every test should be used for specific indication, targeting specific population. Every test is not an all-rounder thing. So judicious use of the test is a must. For ETT, one of the main purpose is to diagnose coronary artery disease, as I have already mentioned. And for the diagnosis of coronary artery disease, the test works most conveniently if we apply this test to those patients having intermediate probability of coronary artery disease. Why? Because in this group of patients, this test has got least false positive and false negative results. If we use this test for a 20-year-old female for diagnosing coronary artery disease, there will be a huge chance of having a false positive result. And if, on the other hand, we use this test for diagnosis of coronary artery disease in a 70-year-old patient who is hypertensive, diabetic, and even having chest pain, in this case, a negative test may be false negative. So the test can perform best whenever it is applied to those patients having intermediate probability of coronary artery disease. How can we define intermediate probability of coronary artery disease?
Please mute everyone else.
We can define intermediate probability of coronary artery disease by two means. One is clinical. What are the clinical markers? The main marker is presence of chest pain and sometimes dyspnea on exertion. And another more specific way to identify the intermediate probability people is to apply the Diamond-Forrester scoring system, which is currently recommended by the American College of Cardiology and American Heart Association. This is not a very complex scoring system. This is rather simple. The main denominators of this scoring system is presence of typical or atypical chest pain or no chest pain at all, and at the same time, age of the patient and also the sex of the patient. As I have already mentioned that the male patients are having more chance, especially the middle-aged men having more chance of intermediate probability of coronary artery disease. On the other hand, female patients, if postmenopausal or at least in the middle age and having typical chest pain, may have got more chance of having coronary artery disease. So the target of ETT is this intermediate probability of coronary artery disease based on this scoring system. And on the basis of this scoring system, we can get high probability, intermediate probability, low probability, and very low probability. And this scoring system even is available in the internet. You can just search this in the MedCalc other softwares. And if you put the age and other information, it will automatically calculate the score. And if the score is between say 10 and 90%, those people are having intermediate probability of coronary artery disease. And for those patients, ETT will work best. Just a few words regarding the behavior of the body whenever we perform exercise. Whenever we perform exercise, heart rate rises and stroke volume also tends to rise, and at some point of time there is flattening of the curve. And systolic blood pressure just increases, but diastolic blood pressure either remain unchanged, or even sometimes there may be some reduction of diastolic blood pressure. And cardiac output certainly rises along with the degree of exercise one person is just performing. And this is a universal truth that whenever a person is continuing exercise, there is increased oxygen consumption. And the main principles working behind the ETT is based on the oxygen consumption of the myocardial tissue. One very important keyword in the realm of ETT is workload. And what is workload? Just the simple sense is that workload means the work or the burden that is imposed on the heart or any other parts of the body. We are concerned with heart today, so it is for heart. And the workload is measured in the unit of METs. What is METs? MET is metabolic equivalent. And metabolic equivalent reflects oxygen consumption and hence energy usage by the body. 1 MET is equivalent to 3.5 ml oxygen per kg per minute. And if we go back to our physiology knowledge, basal metabolic rate means this 1 MET. Even whenever we are in resting condition, our body is continuously just consuming some energy, and that is equal to 1 MET. And as we perform more and more activity, we are just performing more and more METs of works. And the world-class athlete may even perform up to 20 METs of exercise during marathon run. For day-to-day living, just like walking, going to market, these sorts of work activity, at least 5 METs of energy is consumed every day. So 5 METs is a minimum requirements. And if a person can work or exercise 10 METs or beyond, this is prognostically very important, and we can assure that he or she is having very minimum chance of having significant coronary artery disease or acute coronary syndrome in the upcoming days. So this is very important, this concept. So you have to have some points. One is 5 for day-to-day living, 5 METs, and beyond 10, this is a very good status. This treadmill exercise, the ETT can be performed in 2 ways using 2 machines. One is treadmill, as you are just seeing on the left side, and another one is bicycle ergometer. In our country and even in many parts of the world, this treadmill is much more popular in comparison to the bicycle ergometer. In Bangladesh, bicycle ergometer is very seldom seen. One, as far as I know, one is present in BSMMU. The next one is just to make the exercise and whole thing in a customized manner. There are some protocols, established protocols. A number of protocols are available. Basically, the protocols are of 2 types. One is graded protocol and another one is continuous protocol. The other name of continuous protocol is ramp protocol. That is, there is no intermittent change. Rather, there is continuous change of, say, stage, speed, gradient, and MET in that entity. Among the graded protocols, the most popular one is Bruce protocol. You already know. And another modification of the Bruce protocol is modified Bruce protocol. This is to some extent softer protocol, and it is very important for those patients having poor exercise capacity or in the post-MI status. One similar soft protocol is Norton protocol. This is also good for debilitated people, but you should not know everything. Just what you have to know, that you have to know everything for Bruce protocol and some idea for modified Bruce protocol. In the currently available machines, you can perform exercise test following every protocol. There are all options. You can just set up your choice. Few words regarding stages. During, say, Bruce protocol, which is the mostly followed protocol, this protocol, the whole exercise is not prescribed at the onset. Rather, it is prescribed in a graded manner, step by step. For Bruce protocol, the protocol has got a preparatory stage, that is the resting stage, and after that, the main stage, that is the exercise stage, and this is followed by a recovery stage. The main part of the Bruce protocol is exercise stage. And in the exercise stage, Bruce protocol itself has got up to 7 stages. Each stage continuing for 3 minutes. 3 minutes. So the total Bruce exercise protocol lasts for 21 minutes. If someone is capable of going to up to stage 7, he is a world-class athlete, no doubt. The beauty of the Bruce protocol is that it is extensively validated. And it starts with 1.7 miles per hour and at 10% grade. What is 10% grade? Say you are just thinking that a patient is standing upright and the angle between the patient and the horizontal plane is 90 degrees. If you consider this 90 degree 100, and then 10% mean this 10% of this 90 degree. During the change of stages, there is change of speed as well as the inclination. And the inclination means grade. That is the 10% grade, 15% grade, and the change are like this. Whenever there is change of speed, as well as change of inclination, this is more rigorous. The energy consumptions become increased and automatically the METs are increased. So along with the change of stage of Bruce protocol, there is change of METs. But within 3 minutes, there is no change of METs. This is remaining constant. And after the completion of the exercise phase, there is recovery phase. And in the recovery phase, at least you have to take 5 minutes of time. This is a rough estimation. And each recovery phase lasts for 2 minutes. 2 minute recovery 1, 2 minute recovery 2, 2 minute recovery 3, and like this. Sometimes this can be extended even up to 20 minutes or more if indicated. The modified Bruce protocol, as I have already mentioned, that this is to some extent softer protocol. There is 2 additional stages in comparison to the Bruce protocol. Just before the starting of the main stage 1 of the Bruce protocol, there are 2 additional stages. In this stage, like say here, there is no inclination at all. And in the stage 2, there is only 5 degree inclination. And stage 3 is the original stage 1 of the original Bruce protocol. So this is to some extent softer protocol. You need not remember much thing. What is the purpose of ETT? Or in other words, what are the indications of ETT? Certainly the most important indication is diagnosis of coronary artery disease. And another important indication is risk stratification and prognostication in a patient known to have coronary artery disease and even after post-MI. Another important application is functional capacity assessment and sometimes prescription of activity for an individual patient. Evaluation of medical therapy, whether it is enough or not. Evaluation of revascularization, what I have done is enough or not, can be assessed to some extent by ETT. And other applications of ETT evaluation of arrhythmia, even in a patient having PPM implantation or a patient having exercise-induced arrhythmia, or certain, if we want to evaluate whether the anti-arrhythmic treatment is good enough or not, we can adopt ETT. What are the contraindications of ETT? Certainly, there are some absolute contraindications. We should avoid ETT in those cases, like acute coronary syndrome in the acute stage, like within 1 or 2 days, we should not perform ETT. Uncontrolled arrhythmia with hemodynamic compromise. Say, an atrial fibrillation with relatively controlled ventricular rate is not a contraindication. On the other hand, a ventricular tachycardia with hemodynamic compromise is certainly a contraindication for performing ETT. Symptomatic severe valvular stenosis, decompensated heart failure, endocarditis, myocarditis, pericarditis, aortic dissection certainly, and acute pulmonary embolism, pulmonary infarction, DVT. And if a person is not capable of doing ETT, that is having physical disability, he may not have a leg, so ETT cannot be done in those patients. Sometimes bicycle ergometer can be used in modified form. Next, what are the complications of ETT? In general, ETT is a safe test and the risk is very minimum. The major risk can occur only in 1 in 10,000 patients. And what are the major risks? Even there may be death or sometimes myocardial infarction, sustained ventricular tachycardia. These sorts of catastrophe can occur. And to my knowledge, there are some bad incidences in the last 2 or 3 years in Dhaka. 1 death in a private center in Dhanmondi area. 1 cardiac surgeon and NICVD had acute coronary syndrome and ultimately who had to undergo emergency CABG. 1 ST elevation MI occurred at a private center in Dhanmondi, leading to primary PCI, and 1 cardiac arrest at a private center at Shamoli who survived, and that culprit was me. How can we minimize risks? We have to be always very cautious regarding ETT. Otherwise, there may be some bad incidents and that may be a black mark in some clinician's life. We have to ensure trained personnel. Attend yourself during testing. There is some a tendency that the clinician sometimes leave ETT to the just technologists or the technicians, which sometimes may be just SSC pass or intermediate pass person having some sorts of unauthorized training. Mind it, responsibility is yours. So you have to have your caution, okay. Focused history and physical examination is a must. Especially you have to look for murmur, rhonchi, crepitations. And the basic principle is that please, please, please put your stethoscope over the precordium. If you are hearing a prominent systolic murmur, please do not go into ETT unless you are confirmed that the condition is not a grave one. The next one, scrutinize available documents, including resting ECG, and keep vigilant during the whole procedure. Monitor ECG continuously, look for warning symptoms and signs like chest pain, dizziness, and always pay due respect to what patient urges. Sometimes patient may request for stopping the test. Please then stop the test. Do not try to continue if the patient requests. Keep functioning emergency resuscitation equipment. This issue is very neglected in whole Bangladesh, I think so. Please keep your defibrillator and emergency card in your room whenever you are performing ETT. Otherwise, in your lifetime, there may be some sorts of catastrophe. So, pre-procedural checklist includes current medications, which medications the patient is already taking. Unfortunately, there is no uniform consensus regarding withdrawal of beta blockers. Some authorities suggest that you should stop beta blocker at least 1 day before performing ETT, and the other persons are in favor of continuing ETT, beta blocker while performing ETT. And you have to note that whenever the clinician is going to interpret the result, he should keep this in mind that his or her patient was on beta blocker. Demonstrate what to do. This is very important. Before starting ETT or the exercise, please demonstrate in the patient's language what he or she should do in the upcoming minutes. Be careful at the onset. And as our patients sometimes may not be so having so good IQ or just ready, sometimes they not be accustomed. So just at the beginning of the ETT, they tend to fall. So you have to be very vigilant. And my practical experience is that if he or she is just counseled adequately and initially some sorts of support is provided, many persons ultimately can perform ETT uneventfully. Ensure good quality electrodes like Blue Sensor or other brands which are having good contact with the chest skin. Don't forget to take consent because the risk is yours. There are some conditions in which the ETT cannot be interpretable, like if a patient is having baseline left bundle branch block in his ECG, or LVH with strain, or WPW syndrome. These are relatively, these conditions are relatively unsuitable for having ETT. Regarding right bundle branch block, most authorities agree that ETT can be performed and the results can unmodifiably be interpreted in presence of right bundle branch block, whether it is complete right bundle branch block or incomplete right bundle branch. You can perform and interpret ETT safely. Now the question is that if a patient is having, say, left bundle branch block or LVH with strain, he or she should not have any ETT? This is not. The answer is that yes and no. If you are going to interpret the ECG changes only to diagnose the coronary artery disease in a patient with left bundle branch block or LVH with strain, probably this test is not so efficient in those circumstances. But ETT has got some other arms, like ETT can assess functional capacity, ETT can assess chronotropic response, ETT can assess hemodynamic response. These sorts of informations can be adequately attained even in presence of baseline ECG abnormalities. So you have to be judicious regarding the interpretation and use of the information so that you can harvest the optimum benefit from a relatively non-invasive and cheaper test. This is an example of pre-procedural checklist. This form has got some weight, height, what is the purpose, and with the baseline data, and you will be provided with these sorts of information out here. You have to just mark this yourself, mind it. What are the parameters observed? Most important one is subjective complaints. Whether the patient is having chest pain, dizziness, sometimes this aspect is to some extent overlooked, but this should not be done so. Next one is functional capacity. Another one is chronotropic response, which is based on the change of pulse and heart rate. The next one is hemodynamic response. That is the behavior of the blood pressure along with the changes in the exercise during ETT. Mind it, measurement of blood pressure is often inaccurate whenever a person is doing exercise. And this is an Achilles heel for or the weak point for the ETT. Even I try to measure the blood pressure manually during ETT whenever, especially a patient is performing advanced exercise like stage 3 or 4, I am less confident regarding the actual BP reading. So what is the current recommendation? Still, the current recommendation is that you have to perform manual measurement of BP during ETT, not the NIBP. Next important one, and which is the main theme of ETT, is the ECG changes, especially the ST segment, and in addition, arrhythmia, presence of bundle branch block, and certainly you have to pay due respect to artifacts. They are unwanted, but they are the most important and common accompaniment with the normal tracing. Next one is reason for termination of exercise. You have to note this, mention this, and write down this. Encourage the patient carefully to do his or her best. Otherwise, even you are not confident, you can stop the test even at stage 1. I have done so many ETT in my patients. At the initial phase, I was confused whether this lady or this middle-aged man can at all perform a satisfactory ETT or not. But whenever he or she is being encouraged by me, or even more efficiently by my counterparts, ultimately he or she can perform up to a good level. When to stop the test, or what are the test endpoints? The most popular endpoint is based on the target heart rate achievement. Which is target heart rate achievement? There are two nomenclatures. One is target heart rate, another one is maximal heart rate. Target heart rate means 85% of maximal heart rate of an individual patient. And this is true for male as well as for female. So to count the target heart rate, at first you have to know the maximal heart rate. And the formula applied to calculate the maximum heart rate is 220 minus A's. 220 minus A's in years. This is for men, and 210 minus A's in years for women. There is a tendency that whenever a clinician is asked for an ETT, and the cardiologist or the allied person who is performing the ETT, whenever the target heart rate is achieved, he or she is just going to stop the exercise. This is wrong. Unless and otherwise there is indication that you have to stop test, you have to know, you have no other choice. Otherwise, you have to perform or continue exercise up to what the patient can perform. This is the current recommendation. So the current recommendation is symptom-limited maximal exercise performed by the patient. The beauty of target heart rate is that this is a required minimum to say the patient is having negative test or not. But the main purpose of PTT is to perform symptom-limited maximal exercise up to what the patient can perform without any hazard. What are the absolute indications to stop the test? There are some absolute indications, certainly. Drop in systolic blood pressure if this is more than 10 millimeter mercury from baseline, that is before starting the test. This is a absolute contraindication for continuing further test. Moderate to severe angina. If significant neurological symptoms develop like ataxia, dizziness, presyncope, you have to stop. If the patient develops cyanosis, pallor, you have to stop. If the patient requests to stop, always pay due respect to the patient with cautious encouragement that if you can perform to some extent 1 minute or more, the test will be a better one. And with this encouragement, many patients can perform further. If a patient develops sustained ventricular tachycardia, you have to stop. If there is ST elevation more than 1 millimeter in leads without Q waves, V1, AVR, you have to stop. So these are the absolute indications. There are some relative indications. Only one relative indication or two relative indications I like to highlight. One is if there is drop in systolic blood pressure more than 10 millimeter mercury from the baseline, but no evidence of ischemia, this is a relative indication. If there is evidence of ischemia, this is an absolute indication. And another important relative indication for termination of exercise is excessive ST depression. If more than 2 millimeter or marked QRS axis shift, you have to stop the test better. Otherwise, there may be some sort of danger. I will highlight some in some next examples. If there is excessive hypertensive response, like systolic blood pressure if more than 250 millimeter mercury, or diastolic blood pressure more than 115 millimeter mercury, or the combination of the two, this is a relative indication for stopping the test. Unfortunately, the most common reason for stopping an exercise test is fatigue and breathlessness as a result of the unaccustomed exercise. And this is very common for our people, I think so. You have by this time done the main ETT and now get prepared to report. And this is a very clumsy one. If you have got adequate experience and knowledge, then you may be comfortable. You have to comment on exercise capacity in the terms of whether it is poor, fair, or good. Some persons also include excellent. Next one, you have to comment on chronotropic response, whether it is normal, whether there is chronotropic incompetence. There may be complete incompetence, there may be partial chronotropic incompetence. I will highlight this. The third one is hemodynamic response. That is the change in blood pressure, whether the change is normal or there is hypertensive response or there is hypotensive response. Mind it, hypotensive response is always worse than hypertensive response. And the bread and butter is ECG changes. This is the most reliable for diagnosing coronary artery disease. And finally, you have to put a comment regarding the test is positive, negative, equivocal, or inconclusive. Now, regarding exercise capacity, there is no uniform consensus, but a rough guide is that if a person performs less than 6 METs, you can just mark this as poor. If between 6 and 9, this is fair. If more than 9 METs, this is good enough, good. Regarding the interpretation of ECG changes during ETT, mind it, you already know that if there is no change of the ST segment in comparison to the baseline, what is the baseline? Like the resting ECG, the baseline is TP segment. If the ST segment is isoelectric, there is no change. So the test is negative. If there is ST segment depression, but this is upsloping, it may be just a normal behavior of ECG whenever a person is performing exercise. So this is least diagnostic of ischemia. The most important are two types. One is horizontal ST segment depression, and another one is downsloping ST segment depression, like this one, and this is horizontal ST segment depression. And how the ST segment depression or elevation is measured, just 60 to 80 milliseconds after the J point. 60 means 1.5 small squares, and 80 means 2 small squares, 2 millimeter from the J point. Now, what is the unequivocal criteria for positivity of ETT? The unequivocal definition of positivity of ETT is horizontal or downsloping ST segment depression of 1 millimeter or more, horizontal or upsloping ST segment elevation of 1 millimeter or more. Mind it, ETT has got no localization value in general. Whenever there is ST segment elevation, probably in those rare cases, ETT has got some localization value. Otherwise, by just observing the leads affected, you cannot say that this patient is having LAD, this patient is having RCA, or this patient is having LCX lesions. These sorts of localization cannot be actually done. Besides the ECG changes, there are some additional changes or findings in ETT that may be strongly suggestive of positivity. But for declaring positive or negative, you have to rely on only ST segment depression or elevation, nothing else. And all these parameters are just suggestive, but not diagnostic of positivity or negativity. What are those features? Horizontal or downsloping ST segment depression if less than 1 millimeter, upsloping ST segment depression more than 2 millimeter, hypotension, inverted U wave, frequent multifocal or grouped PVCs, ventricular tachycardia provoked by less than 70% maximal heart rate, increased R wave amplitude, exercise-induced typical angina, third or fourth heart sound or heart murmur. All these features are suggestive of positivity, but not confirmatory. Now, how can you make the final impression? Just, this is very controversial issue, but for general purpose, only 4 terms may be enough. One is positive, one is negative, one is equivocal, and the last one is inconclusive or uninterpretable. You often encounter a language, stress test is positive for provocable myocardial ischemia. And this is a very good saying. There are some fallacies regarding the interpretation of ST segment changes. If we set up the point at 1 millimeter, the sensitivity is relatively low, but the specificity is high. And if you define the positivity by 2 millimeter horizontal ST segment or downsloping ST segment depression, the sensitivity becomes less, but specificity becomes very high. In your clinical practice, sometimes you will get some strange things, like there will be no ST segment changes during exercise, like here, but whenever there is recovery, there is significant ST segment depression, and this is horizontal or downsloping. And what is the interpretation? The general consensus is that the interpretation is like that of exercise stress, that is positive. If isolated ST segment depression, horizontal or downsloping occurs in recovery phase, not in exercise phase, still the test is positive. Mind it. I think most of you have heard the term Duke Treadmill score. What is this? To make the ETT more practical, more efficient, in other words, to increase the efficiency of ETT to decide upon the diagnosis of coronary artery disease and to put the patient for coronary angiography, some scoring systems are available. Not only positive, negative ETT. And one of the mostly followed scoring system is Duke Treadmill score. This is another very interesting and also very simple scoring system. At first, this may be to some extent cumbersome because we do not practice this. But if we practice this, this is a very good one and simple one. Most of the machines have got automatic setup for calculating Duke treadmill score. If you give this input, the machine will automatically give you a score. The Duke treadmill score is used in patients without non-coronary artery disease undergoing treadmill ECG testing. And this tool is for predicting risk of myocardial ischemia or infarction. How is this calculated? Exercise duration by Bruce protocol. Mind it, this is only applicable for Bruce protocol, even not for modified Bruce protocol. Exercise duration by Bruce protocol minus 5 into maximum ST elevation or depression in millimeter minus 4 into angina index. What is angina index? Very simple. Just if there is no angina on treadmill, index is 0. If angina occurs, but this does not compel the patient to stop further exercise, this is 1, score is 1. And if angina caused termination of exercise, the score is 2, angina index is 2. And whenever you are putting all these things in the software, the software will automatically calculate a score. The score may be positive, may be negative. Positive numbers indicate good prognosis. Negative numbers indicate bad prognosis. Lowest risk is for +5 or greater. That is more positive. +5 or more, risk is lowest. Future risk is lowest. And if the score is between 4 and -10, this is moderate risk. And highest risk is having those unfortunate persons having score -11 or even more minus DTS score. In those cases, the risk is high and 1 year, 2 year, and 5 year mortality is very high in those patients. And those patients should undergo more urgent coronary angiography. So how to use DTS? DTS is a validated tool for risk assessment for coronary artery disease. Based on DTS, clinicians may decide upon coronary angiography, as I have already mentioned. If DTS is high, CAG should be considered. And finally, this will be the form. You have heard one term. This is submaximal ETT. What is this? When a person or a condition does not favor to perform adequate exercise to attain the target heart rate, you can just lower the point. And in those cases, that ETT is called submaximal ETT. This is especially done in ACS patients pre-discharge, before discharge from the hospital. The most popular cutoff point for submaximal ETT is 70% of maximal predicted heart rate. Mind it, for optimum target heart rate, this is 85%. And here, the value is set at 70% of maximal predicted heart rate. Certainly, there are other definitions of submaximal ETT. I am not going into those details. I have already mentioned, look at this. There are some practical examples here. This is a pre-exercise ECG tracing during ETT. And you are mentioning that the quality is reasonably okay. But when the patient is in stage 2, there are so much artifacts that it will be very difficult to interpret the further ECG changes. But when another tracing is taken at 1.5 seconds of recovery, 1 minute 50 seconds of recovery, the tracing is again a beautiful one. So what to do? If you perform, say, ETT for 10 patients, certainly for 1 or 2 patients, there will be huge artifacts. And what should be done? How can you avoid this? Despite all your efforts, the artifacts will be present. And one practical tip is that please take a ECG tracing whenever the patient stops exercising, even on standing on the machine, preferably within 10 seconds of stopping exercise. Whenever the patient is still on the ETT machine, standing, but not running or walking, please take an ECG tracing. And that ECG tracing, which is taken within 10 or 15 seconds of stopping exercise, will be very, very much close to the and representative of the advanced exercise ECG tracing. The beauty of this ECG is that you can comfortably interpret without much artifacts of the ECG changes. And this is very practical tips. I regularly practice this thing. This is a practical tip. Please try to follow this. Look at this. This is certainly a positive ETT. And this patient is having significant ST segment depression, horizontal ST segment depression in stage 1. So this patient is having positive ETT at very low workload. There may be some sorts of comments like this: poor exercise capacity, because the patient just performed 3.5 minutes and then we have to stop the test. Normal chronotropic and hemodynamic response, though these parameters may not be adequate to comment on whether this is adequate, normal or not. And the last one is that positive for evidence of exercise-inducible myocardial ischemia. I have already mentioned that there may be ST segment changes just only in the recovery phase. Like here, this is the stage 2 exercise, almost no change. And this is the 3 minutes and 50 seconds of the recovery. And you are seeing that there is significant downsloping ST segment depression as marked here. Another example, this is a 53-year-old man who was diabetic and smoker, who was having ETT at NICVD for screening for coronary artery disease. And during the stage 1 tracing of this patient, look at this. This is relatively just unremarkable. Some ST segment elevation is just occurring. And unfortunately, the patient was complaining of chest pain. And whenever the tracing of stage 2 was analyzed, there was significant ST segment elevation in many of the leads. So the patient was having ST segment elevation induced by exercise during ETT. And this ST segment elevation persisted even after 4 minutes of recovery. And whenever troponin was available, this was positive. So in this case, ETT led to myocardial infarction. So always be cautious. Sometimes in your lifetime, you may encounter these sorts of unfortunate incidents. This is another patient, 46-year-old man with exertional chest pain. And this is the pre-exercise ECG of this patient. You all agree that this is normal, unremarkable. But when just stage 3 tracing was analyzed, there was significant ST segment depression in many of the leads. And if we compare this with the previous one, there the positivity is at a relatively higher workload. And the patient has got severe fatigue. 10.2 minutes was already performed. And whenever coronary angiography was done, there was excellent correlation with the ETT findings and the angiogram, as you are seeing a significant lesion in the LAD. Sometimes you may encounter some equivocal ETT, like here. This is a 38-year-old gentleman. And this is the pre-test tracing of the patient before starting exercise. And you will agree that this is a relatively normal one. And when stage 4 tracing was taken into consideration, there are some ST segment depression and mostly upsloping ST segment depression. And you may be in doubt whether this is positive or negative, whether this is significant or not. In those cases, if you are not sure that this is negative or positive, and also the patient has just of an adequate age and sex, in those cases, you may better write down this as an equivocal test. Like here the patient has attained target heart rate and he complained of general fatigue and thirst. Exercise time was 9 minutes 21 seconds. And ultimately he performed 11 METs, more than 11 METs. Maximum ST segment depression was 1.6 millimeter. So the impression was good exercise capacity, normal chronotropic and hemodynamic response. Target heart rate was achieved. Up to 1.6 millimeter ST depression, mostly upsloping, occurred during exercise, which rapidly returned to baseline in recovery. Just you are giving some additional information for the clinician. The final judgment will be on the hand of clinician, him or herself. And the test is equivocal for evidence of exercise-inducible myocardial ischemia. So you can write down such sorts of comments. Just mind this. Some of you may not agree with my interpretation, but this may be one example. Another example of positive exercise ETT in recovery. Stage 2, still no change. And when recovery, early recovery, no change. But after 4 minutes in the recovery stage, there is significant downsloping ST segment depression in many of the leads. So the comment should be positive. Now the story of a 48-year-old hypertensive man with normal ECG. Just baseline ECG was normal, and he was diagnosed as a case of chronic stable angina and hypertension. Whenever ETT was performed, he performed a very good one, 9.8 METs. Chronotropic and hemodynamic response was good, but there was positive evidence of exercise-inducible ischemia. Like here, this is the pre-test ECG, and this is the stage 3 ECG. Look at this. This stage 3 ECG and the significant horizontal ST segment depression noted in multiple leads. You all agree with me that this is significant. This is significant. But unfortunately, the coronary angiography report was normal. So this may be a good example of false negative ETT. Some persons may give the reasoning that it may be a case of syndrome X, maybe, may not be. Don't make a mistake. A 35-year-old man was prepared for ETT. Pre-procedural evaluation form was duly filled up. 12-lead ECG was not available. Pre-test ECG raised question. Just I was asked to start the ETT, and I have a swift look in the available documents. And when I looked at the resting ECG, there was significant changes which inhibited me to continue with the ETT, though the patient was asked to perform ETT by a gastroenterologist. Look at this. This was the pre-exercise ECG, and there was significant Q waves already in the many of the leads, and also significant ST depression. If I left the patient on the hand of the technologists or technicians, there may be some sorts of catastrophe in that case. After that, I performed a 12-lead resting ECG, and again, the presence of myocardial infarction was evident here. So don't leave the patient to the assistant or technician only. Always gather necessary information, including ECG. I am giving much emphasis on this. Mind it, liability is yours. This is the story of a 44-year-old man with corrected PGA and Epstein anomaly of tricuspid valve. And this patient was referred to me for ETT by an electrophysiologist of Dhaka. And when I went through the available ECG of the patient, I was a bit hesitant regarding performing ETT. And look at this, you will agree with that the patient was having complete heart block. I was especially hesitant because I was to perform ETT in a private center without any inpatient facilities. However, I proceeded through the ETT, and ultimately, to my astonishment, the patient was performing stage 1, stage 2, stage 3, and even in stage 4. And there was significant increase in ventricular rate. What is the beauty of this ETT? The beauty of this ETT is that I am sure that the electrophysiologist did not refer me, the patient, to comment on whether there is ischemic heart disease or not. Rather, he was eager to know the behavior of the rhythm with exercise. Look at this. That patient performed 13.4 METs. Even I may not be able to perform that up to that level. And the chronotropic response was partial. Is this patient actually a candidate for PPM? No. No need for PPM because he or she is competent enough to continue with his day-to-day living. So all feet tread not in one shoe. In all the ECGs, you should not make the same types of comments. Like here, the comment was good exercise capacity, chronotropic incompetence was observed. However, with increasing workload, ventricular rate increased slowly to a maximum of 107 beats per minute. BP response was also slow and inadequate. No significant ST changes occurred during the test. So I am going to put more emphasis on that. Here you have to give more attention to the behavior of the chronotropic response and also the hemodynamic response of the patient to exercise during ETT. This is another important purpose of performing ETT, mind it. And with this ETT result, probably the electrophysiologist will confidently avoid putting a permanent pacemaker for the patient. Now, an example of exercise-induced arrhythmia. This is a 50-year-old man who developed chest pain in stage 1, like here. And when the rhythm was analyzed, there were certain ventricular runs of ventricular extrasystoles. So, along with positivity, there is exercise-inducible ventricular arrhythmia in this particular case. Whenever you encounter appearance of ventricular extrasystole, 1, 2, single, double, couplet, bigeminy, but no other evidence of ischemia marked by ST segment changes, these are not indications of positivity. But you have to mention this in your comment that such sorts of arrhythmia have appeared or disappeared, or when disappeared, you have to mention this. This is another example. This patient was having exercise in ETT in NICVD, and when ETT was continuing, there was significant regular narrow complex tachycardia, even up to 230 per minute, probably supraventricular tachycardia. This is exercise induced. And these supraventricular tachycardia persisted long after the recovery phase. In this particular patient, up to 15 minutes of recording was performed, and the rate was like this one up to this. And this patient was then accordingly transferred to the CCU, and he was managed with pharmacological maneuvers. With this, I like to conclude with some take-home message. ETT serves better in patients with intermediate probability of coronary artery disease, though non-invasive, potentially dangerous, unsuitable in presence of left bundle branch block, left ventricular hypertrophy with strain, and WPW syndrome. But even in these cases, ETT can give you some valuable comments regarding the chronotropic response, hemodynamic response, and like these things. Generally done as symptom-limited test. ST segment deviation is the single most important parameter for interpretation. Horizontal or downsloping ST depression of 1 millimeter or more, or horizontal or upsloping ST segment elevation of 1 millimeter or more defines positivity. But certainly 2 millimeter, another option, has got no localization value for coronary artery involvement. Mind it, not like resting 12-bit ECG, it does not have any localization value. Artifacts are the Achilles heel of ETT. So you have to be knowledgeable and judicious whenever you are performing and interpreting ETT. And then in those cases, ETT can guide you much in your clinical life. With this, thank you very much for patient hearing.
Thank you so much. Excellent talk, as usual. Really exciting session where everybody delighted your presentation. Yes, in my point of view, I'm so much busy in patients. Usually, I avoid the ETT because I have enough time to stay beside the patients. So I usually refer the patient in another center. But one thing is I always find out before referring. It is tracing. Usually, lots of artifacts in the machine in our center, in private center, number one. Number two, there is no expert technician beside the patients, number two. Number three, the referred physicians, the physician who cardiologist is reporting, he are not present in the patient's side. So I usually refer the patient in NICVD. Till now, I prefer the NICVD because the technician is expert in NICVD. They are encourage the patient to please, you go ensure the patients overcome this. Dr. Adut sir, please comments regarding the ETT, your experience and comments.
Thank you, Dr. Monwarul. It was a beautiful lecture and it was very well presented and it encompasses all the important points. I think one or 2 points may be more emphasized. When you have ETT changes in inferior leads, most of the time it has less value. Whenever you have change, particularly involving lead V5 or V6, it is much more sensitive and important. Your comment, please.
Yes, sir. I do agree with this. And certainly, we have to be cautious regarding the interpretation of ETT whenever these isolated changes are present.
I like to say something.
And the same, sir, the same principle applies to echo even.
Yeah.
If you encounter isolated hypokinesia in the basal inferior segment or basal segment of the interventricular septum, always be cautious regarding mentioning that you are dealing with coronary artery disease. And this is also applicable for even MPI.
Yeah. Can I add something? And
Can I add something?
Important that while interpreting the ETT, look at the MET level. ETT, which is positive at a very high workload, most of the time, the patient do not require any intervention or any angiogram. Because it has been said, if you have the exercise capacity of more than 13 METs, the likelihood of a major cardiac event occurrence within 1 year is less than 1%. So that almost excluded. Number two, in a pre-operative non-cardiac surgery evaluation, when can we advocate, if even in a known patient of coronary artery disease, when can we advocate the patient can undergo surgery under general anesthesia? Is there a cutoff value or something like that?
Sir, yes, sir. This is a very important and practical issue. The consensus is that if some patient is having history of, say, PCI within 2 years or CABG within 5 years, you need not do anything. If a patient can perform 5 or 4 METs, what is the definition of 5 or 4 METs? Say if a patient can climb 1 stairs comfortably, you need not go for ETT. In those cases, you can safely conclude that your patient can sustain the surgery with GA.
Perhaps there is some study suggesting that, but for legal value sometimes, it's imperative that there is no documentation that the patient can claim. That's patient's words against your words. So for legal value, if you want to do non-cardiac surgery evaluation, if the patient can perform up to 7 METs, the chance is that there will be no problem during general anesthesia. Up to 5 METs, the patient can be cautiously given general anesthesia. Less than 5 METs, no, you have to do something else to evaluate what is the status of the coronaries or otherwise.
Thank you, Dr. Jamil. Dr. Jamil? Dr. Abdul Jamil. Yes, sir.
I want to mention what Dr. Wadud pointed out. The V5, V6 is the earliest change, any ischemic event in the heart. It is manifested in V5 and V6, and this is the earliest change comes and more specific than any other leg. And in echo, the basal inferior segment is naturally hypokinetic by its anatomical position, and it should not be reported in the impression. It can be described in the description that the basal inferior segment is mildly hypokinetic, but that should not be put in the impression. And for this reason, we get so many referrals from a surgical side or anesthesia that need cardiac opinion regarding further management of non-cardiac issue. Another thing, what Monwarul pointed out about the equivocal report, a patient achieved more than 11 METs, and there was upsloping ST depression. Even it is after the 80 millisecond, I interpret as it's negative, as because it is in very high workload, it is positive. So this is this type of patient when undergo coronary angiogram, usually it becomes normal.
Thank you, sir. Lots of questions in the chat box because fellows are very much interested to asking question. Dr. Shubro, please, Dr. Shubro, please put the question. A brief question.
Thank you, sir.
Question here. Yeah.
Thank you, sir. Thank you, sir, Monwarul sir, for excellent presentation. Actually, it is a very burning topic. I have got few questions. First of all, sir, what is
one question, Dr. Shubro? Only one question.
One question. Okay. Then I want to know that sir has said that in case of LBBB, it can be very difficult to interpret. But what in case of RBBB? What will be in case of RBBB, right bundle block?
I have already mentioned, this is a good question and practical issue. The consensus is that most of the authorities agree that in presence of RBBB, you can safely perform ETT and safely perform the ECG changes, even like those patients having no RBBB. So RBBB does not hamper or interfere with the interpretation of ECG changes of it.
Okay, sir.
Can I add something?
Yes, sir.
During ETT, if you have so-called VT or something like that, many of the time it's actually not VT, it is exercise-induced, rate increase-induced RBBB. So if you see the PVC or the so-called non-sustained VT of RBBB morphology, if the patient do not have symptom, you can proceed a little bit further. But if you see the patient has LBB type PVC, you should be very careful. Monwarul, your comment.
Sir, I agree with you, sir. And another important clue is that sometimes, say you are performing ETT in presence of right bundle branch block, and you are saying that there are some sorts of wide complex tachycardia. How can you differentiate whether just you are dealing with RBBV with sinus tachycardia or just a VT? The dictum is that if there is change of axis, like in V1 and V6, the shape and direction of the positivity becomes changed. This indicates that you are dealing with a new arrhythmia, that is probably VT.
One thing, Dr. Monwarul, till now, some of the report still some fallacy regarding the upsloping, downsloping, and horizontal. So reporting is some incorrect interpretation. During the you should see the ECG minutely before reporting upsloping, downsloping, and horizontal. Second one is ventricular ectopics. You just discuss about the ectopics. In the stage 1, you find out the ectopics. Sometimes we found in the recovery phase of ectopics. Regarding this, lots of questions regarding the ectopics. Dr. Monwarul, please tell something that.
Right. This is another important practical issue. Sometimes whenever we are performing or deal ETT, ectopics are present before starting exercise in the resting ECG. And in that case, if there is no myocardial infarction or any of these things, you can perform ETT cautiously, keep vigilance, and just note what is the behavior of the extrasystoles, whether the extrasystoles are increasing in number and complexity, like the single extrasystoles are becoming couplet, bigeminy, trigeminy, short runs, or like this. In those cases, you have to stop. Or if extrasystoles rather disappear with advancing exercise, it indicates that those extrasystoles does not bear much pathological significance. And probably those extrasystoles are relatively harmless.
Thank you. Dr. Swadesh raise his hand. Dr. Swadesh, please ask a question.
Thank you, sir. Thank you, Monwarul, sir. It is always pleasant to hear from Monwarul, sir. ETT, day by day, day to day, ETT raises many questions and many issues. I want to know one thing or one comment from Monwarul, sir. Sometimes we find the patients achieves target very early stages, like stage 1 or early stage 2, or 4.5 or 5 minutes exercise, and patient have the target 85% or 90%. Should we comment this ETT negative, or should we terminate here?
This is another practical question. For these regions, the present recommendation or current recommendation is to continue ETT if there is no other compelling indication to stop, up to what the patient can endure. That is symptom limited, not target heart rate limited. Target heart rate achievement is a required minimum, but you have to continue if the patient can continue. Up to what the patient can continue, then only stop exercise. Many patients can achieve even in the resting stage the target heart rate. And then you continue the ETT, the patient may sometimes attain up to stage 4 before having tiredness or like these things. This is the more efficient way to be sure on positivity or negativity or presence or absence of coronary artery disease by ETT.
Can I add something?
Yes, supplement questions.
I have observed that because the many center technicians are doing it, patient can exercise more. Patient is telling that, sir, I could have achieved much more, but the technician is stopping it just after reaching the target heart rate. These ETTs are very bad. You cannot actually interpret or properly interpret these ETTs. And we
right,
have
sir.
about that.
And
So
even this practice,
Dr. Monwarul, may I supplement the previous
Yes,
question?
Yes.
Yeah.
That is an excellent lecture, definitely, no doubt. And if patient stopped because of fatigability and target heart rate in the meantime achieved, right? In that case, what would be the interpretation? It is negative in low workload, or it is inconclusive. Whenever target heart rate already been achieved,
if target heart
it
rate
is stopped
is
in early stages.
Yes, like stage 2.
Right.
In that case, you can comment that the test is negative because there is no ST segment depression or elevation or like these things. But you have to mention that the exercise capacity is say poor or fair.
To say positivity target heart rate is required.
Right.
Dr. Professor Khalid Mohsin, sir. Lots of fellows are waiting for question.
Okay, thank you, Monwarul. And you have rightly emphasized about selecting the right patient for the ETT. Actually, if the patient is having a class 3 or class 4 symptoms of angina, subjecting the patient to ETT can invite trouble. And in this group of patients, it is better to avoid ETT and subject the patient to coronary angiography straight away, because this sort of patients are likely to cause a lot of problem. And I remember one instance when the national cricket coach of Bangladesh team, Gordon Greenidge, was referred to NICVD once for an ETT, and the performing doctor was in a real mess. His heart rate was not increasing. He was crossing one stage after another, and after crossing stage 6, he had to stop, and he was not able to interpret the ETT properly. So, so this was a real troublesome scenario. So regarding world-class athletes, I think ETT is not a very good test to advise for.
Right.
I want to invite your comment. There are some terms like the poor man's ETT test. One is the post-extrasystolic T inversion, and another is the 6-minute walk test. Sometimes it is being practiced sometimes. What's your take on these two issues?
Sir, I like to add another term, master's 2 steps exercise test.
Yeah.
Poor man's exercise test, though, just sir have already mentioned that this is post-extrasystolic changes. And sometimes this can automatically, without investing 2,500 taka or more, you can have some idea regarding the ST segment changes. But another interesting one is 6-minute walk test. This is a very up-to-date, very practical test, very simple test, but often neglected test. This can give a good idea regarding the functional capacity and the prognostic value with treatment, without treatment of a patient. And it can even be performed in NICVD or anywhere without much machineries or investment. And the last one, the master's 2 steps exercise test. I can remember when I was in 5th year, MBBS 5th year, I took one of my relative to the chamber of Professor Nesaruddin Ahmed. And there I noticed that sir was advising a patient to up and down, climb the stair and then coming down, up and down. And then sir just took an ECG. So this was an example of master's 2 steps ETT. And this was the just first attempt to invent the ETT in the past years, in the very beginning of the ETT, history of ETT.
Thank you. Thank you, Monwarul. Lots of questions in the chat box. Dr. Arifimon Sajal. Dr. Arifimon Sajal.
Okay. Thank you, sir. There are lots of questions. Very interesting topic. It's a very important topic also. One question is, why should beta blocker be stopped before ETT?
This is also a very good question. Beta blocker has got negative chronotropic effect. And for this negative chronotropic effect, the target heart rate, which is a bread and butter for ETT cannot be achieved so easily. And if target heart rate is not achieved, then the your comment or decision regarding the positivity and negativity may not be possible. Number one. Number two, because of the presence of beta blocker, sometimes the blood pressure response to exercise may be blunted. For these reasons, a beta blocker sometimes may be an issue for interpreting or continuing further exercise tests. But if you stop ETT, sorry, beta blocker 1 day beforehand, the problem is that there may be rebound hemodynamic and chronotropic effect, which may again interfere with the risk of the ETT. So this is a controversial issue, but the current opinion is more in favor of continuing beta blocker.
One thing I want to add with Dr. Monwarul is that if you continue the beta blocker and do the ETT, it will reduce the sensitivity of the test. At the same time, it will increase the specificity of the test.
Yes.
Number one. Number two is that when the patient is on beta blocker, the target heart rate will be a bit lower than the without beta blocker. Around 75% of the is created. Yes. At the same time, I want to put one question to Dr. Monwarul. Suppose before starting the exercise tolerance test, patient has got normal sinus echo and there is no bundle branch block. But with continuation of the stages, patient developed left bundle branch block and mild chest discomfort. What will your impression and will you continue to proceed further?
Sir, the general consensus may be that presence of left bundle branch block or right bundle branch block should not compel you stop. You can cautiously proceed further and follow up the presence of chest pain. If the chest pain get worsened, then certainly you have to stop this. And presence of right bundle branch block or left bundle branch block during exercise is not an indication of positivity or negativity.
Thank you.
Monwarul bhai, Sohail bhai, আমি কি প্রশ্ন করতে পারি?
And Dr. Ajay, please, a question, just put a question is in brief. What's the question?
Okay. Okay.
Ajay, please.
Thank you, Monwarul bhai, for your excellent lecture. Actually, I want to know if you have any experience on post-STEMI patient where pre-discharge ETT can be done to evaluate the residual ischemia even after thrombolysis. Do you have any experience to see the residual ischemia in post-thrombolytic patient?
No.
Pre-discharge ECG.
Almost no, because this is not practiced in NICVD. Because another important cause is that the rehabilitation after MI is a neglected issue in our country and centers.
Actually, the aim of this question was to see the residual ischemia. Actually, we do ETT to see the inducible ischemia. That's why if there is any residual ischemia after thrombolysis, we can assess by pre-discharge ECG to see that is the patient complaining any angina. That's why in our country where PCI is not available post-STEMI patient after thrombolysis, most of the patients are not able to do PCI. And if we categorize the patient, which patient will benefit from cath, can we practice this to see the residual ischemia during discharge?
Thank you, Ajay. Excellent comment, because I should do practice in rehabilitation. Dr. Wadhu sir, please. Wadhu sir.
The point is, nowadays the consensus is that after thrombolysis, you should go for pharmacoinvasive PCI, either rescue or routine, angiogram and PCI if needed. As Ajay was saying, in many parts of the country, that is not possible. Only then it's validated that only we should select those patients who really need further intervention by doing an ETT. But again, I do think proper interpretation of ETT is very neglected in most part of the country. Mohsin,
Arif, Dr. Arif. I did. Why ST depression reappear in recovery phase? It is considered as positive or any mechanism of this?
ST depression occurs isolated, just only in recovery phase.
Yeah, yes.
ST depression occurs only in recovery phase. This is actually the pathophysiology behind this may not be adequately known. One important suggestion is that after of the exercise, the person should be kept in lying position. One suggestion, like from Hurst, because whenever a person is supine position, there will be more and more hemodynamic stress on the left ventricle, giving more burden on the left ventricle. And whenever a person is not adequately positive during the exercise, he or she may be positive even in the recovery phase in recumbent position.
And Dr. Monwarul, a patient comes in chamber, patient blood pressure is 160 by 100. Advise ETT. What should you do during this patient? Start ETT or what your protocol? If blood pressure is 160 100. Someone,
if you particularly fix the point that 160-100, I will perform ETT. Just because I do not leave any patient on the hand of my technician. I myself becomes by the side of the patient and encourages to do what he or she can do.
But can I make a question?
Any drug, or you can wait 1 hour after doing the ETT? Put a drug, or you're waiting for 1 hour and relax at the patient's waiting room at 1 hour.
Actually, there is no opinion regarding just stat administration of an antihypertensive drug and then going to proceed ETT with the controlled blood pressure. I do not found any comment or suggestion from anywhere.
I think assurance of the patients.
Assurance just to make him calm down. And then if the blood pressure is unacceptably high, I can rather postpone the procedure for another day, at least. And if not, the blood pressure is just only mildly elevated. In that case, I can continue with the test cautiously.
Yes. Any other question, please?
Professor Sundar Banerjee sir here. Professor Sundar Banerjee sir, do you hear me? Sir.
Machine.
Sir, thank you.
Machine, আমি মনোয়ারের লেকচারের জন্য বসে আছি কমপ্লিট হওয়া পর্যন্ত। তো মনোয়ারের লেকচারটা খুব এনজয় করেছি। মনোয়ার, একটা কথা, ওই যে হাইট অফ দ্য আরওএফ,
জি স্যার,
এটার ইম্পর্টেন্স ইটিডিতে, এটার একটা কিছু কথাবার্তা আছে
স্যার। জি স্যার,
একটু বলেন না
স্যার। হাইট অফ দ্য আরওএফটা হচ্ছে যে কয়টা ইটিটি প্যারামিটার স্ট্রংলি সাজেস্ট করে পজিটিভিটির মধ্যে, কিন্তু ক্রাইটেরিয়া ফর পজিটিভিটি নেগেটিভিটি না, তার মধ্যে একটা হচ্ছে হাইট অফ আরওএফ। এই হাইট অফ আরওএফ যদি 25%-এর চেয়ে বেশি বাড়ে অথবা যদি কমেও যায়, দুইটাই সিগনিফিক্যান্ট হতে পারে। দুইটাই সিগনিফিক্যান্ট হতে পারে।
রাইট। লেফট ভেন্ট্রিকুলার ডিকম্পেনসেশনের জন্য ভেরি ইম্পর্টেন্ট।
জি স্যার, জি স্যার।
খুব ভালো প্রেজেন্টেশন হয়েছে মনোয়ার।
Thank you, sir. Dr. Doctor, do you hear me?
Yes, I can hear you.
Yes. Any comments?
So first comment, thanks IPDI for beautiful arrangement, and thanks Mona. This is a beautiful lecture from A to Z. I have heard you, and a lot of new things I have got from you. So thank you very much. And regarding beta blocker, stopping beta blocker. Although, sir, I have one question. Suppose a patient is on anti-ischemic drug without evidence of ischemia. In that case, beta blocker is stopping beta blocker, and to see whether the patient has got ischemia or not by doing the ETT is an important issue. But if the patient is already established ischemic heart disease, in that case, it is better not to stop beta blocker. But with beta blocker, whether he can continue exercise, how much exercise tolerance he can tolerate, how much ECG change will happen with beta blocker, that is important. Whether he will go for further invasive procedure or not. But if the patient, first time you want to diagnose the case, whether ischemia present or not, whether he needs anti-ischemic therapy or not, in that case, it is better to stop beta blocker at least 24 hours back. Another thing, what Udit sir was telling, ST depression, inferior lead is always less importance. Then V5, V6, definitively that is important. But I have seen that ST depression in V1, 2, 3 is more specific and more dangerous. Even upslope ST depression in V2, 3 sometimes is very dangerous in presence of symptoms of the patient. This patient, I have seen that they have got LAD proximal lesion. Even there is no downslope or horizontal ST depression. And I have one question to Dr. Monar. In LVB patient, suppose someone intermittent pre-syncope or syncope, is there any role of ETT regarding chronotropic response or development of 2:1 AV block or something like that? ETT has got any role regarding this LVB patient?
Yes, sir. Yes, sir. I have already mentioned that the only purpose of ETT is not to diagnose coronary artery disease. It has got other purposes like evaluation of arrhythmia and the presence of left bundle branch block, whether it is associated with extensive involvement of the conduction system of the heart or other parts of the conduction system of the heart. Certainly we can cautiously perform ETT. And if it progresses to higher level of blocks, it is certainly indicative of maybe requirement of permanent pacemaker.
Yes, thank you. And another question regarding site of ischemia in ECG change. If there is ST elevation, suppose in the inferior lead or suppose in the lateral lead, is it specific for that particular segment ischemia or
yes,
ST
sir,
depression
yes,
is not specific for
yes,
site
sir,
of
yes, sir,
ischemia,
yes,
but
sir,
ST
yes, sir,
elevation?
yes, sir, yes, sir. This is a very good question and issue. Actually, ST segment depression has got no localization value, though ST segment depression is most commonly seen. But if you are lucky enough to encounter ST segment elevation, then it may localize the coronary artery lesion involvement. That is, it has got localization value.
This is very important. Ashok has raised very important question about that. And regarding beta blocker, if a patient is hypertensive, if you want to assess the ischemia, if you want to avoid the controversy, you start a calcium channel which is not rate limiting, then send the patient for ETT. So you won't have any problem regarding antihypertensive treatment and the issue of not increasing the heart rate properly. Another thing is that, please, before starting ETT, always ask the patient about chest pain. Do not left it at the hand of the technician. For many of the cases, I find the patient is having the 3+ angina and the doctor is sending the patient for ETT. This is a crime. Because if you take the history properly, you come to know what sort of angina the patient is having, the quality of angina, the duration of the symptoms. Why should you send the patient for ETT? You should send the patient for ETT only in class 1 angina and for evaluation in class 2 angina. Class 3 angina patient do not require ETT. Your history should be good enough for that. We should be careful about that.
Thank you. Professor
Sir, I want to add a comment to Dr. Ashok. Just single word.
Yes.
Okay. Actually, ST depression in stress and ST elevation in stress, they have two pathology. I think ST depression is subendocardial ischemia and ST elevation is transmural ischemia. In that sense, ST elevation dictates us this patient should go immediately for cath to do revascularization. This is the very important thing. If any patient appear ST elevation in stress, this patient is very much very urgent. Patient needs revascularization, I think. Thank you.
Professor Pavit Kumar Das. Thank you, sir. Professor Pavit Kumar Das. Please unmute, sir.
Robita, unmute Karen. Yeah.
Okay, thank you. Am I audible now?
Yes.
So thanks to Monwarul. Very entertaining presentation as well as the interactive discussion. Is it ETT or TMT? We people in our country call it ETT, but our Indian friends frequently call it TMT. TMT means treadmill test. And the meaning of ETT is possibly not only exercise tolerance test, it is also exercise treadmill test because it is done in treadmill machine. So with advent of more and more use of coronary angiogram, possibly the diagnostic value of ETT is much less. Rather, the prognostic value is much more. Many things has been discussed. One thing possibly is not very highlighted is use of this ETT in female. Many of us are of the opinion that most of the time ETT in a female is false negative or false positive. Is not always true. The latest recommendation is in a female presenting with atypical chest pain or some symptoms suggestive of some cardiac involvement, if ETT is done and if the ETT is negative, she does not require further testing. So this is very important. For female, ETT is can be advised, and if a negative ETT in a female excludes further testing, and newer, more sophisticated testing for the female is not usually needed. So this view what I conclude. Thank you all.
Dr. Monwar.
Yes.
Regarding the female patient and ETT, because we are really depressing when I advise the ETT for the female patient, because they cannot run properly in the stage 1, stage 2, fatigue and breathlessness. So what do you experience regarding the female patient during repetition of ETT? As Dr. Kovi says, it is negative. But before, why you conclude this ETT patient, female patient ETT negative? Because you can run stage 1, stage 2 properly. Dr. Monwar.
Thank you. This is a very important question, though to some extent having racial or gender issue. Actually, females should have ETT.
Yes.
And if you just take into consideration the exercise level and day-to-day activity of the lady, and if you encourage, most of the patients can perform, though not very high, but up to the required level, I think so. So I routinely do ETT in female patients as well.
Sir, comment regarding female patient and ETT.
আচ্ছা, সেটা না মনোহর ঠিকই বলেছে। আসল কথা কি জানো, যে ফিমেল পেশেন্টের যখন সিমটম হয়, সিমটম ইভালুয়েট করে আদৌ তার কার্ডিয়াক ইসকিমিক চেঞ্জ কিনা, নাকি তার ব্রেস্ট ইস্যু, নাকি জার্ড হচ্ছে, জিআর, সেটা আসলে বোঝা উচিত। আমার রাজীবের একটা কোশ্চেন খুব পছন্দ হয়েছে। সে প্রশ্ন করেছে, if there is ST depression at the starting of ETT in stage 1, let's say, but it disappeared during ETT, what would be the interpretation?
Actually, this may rather indicate negative.
Yes.
Okay. Because if there is ischemia, this should persist.
Sir, can I comment?
Yes.
Actually, it is equivalent to start of angina. Sometimes the patient, when starts exercise, patient complains of chest pain, but after sometimes the patient disappear the symptom because of establishment of collateral flow. And this is practically seen that established. Yes.
The ST depression.
And that's why ST depression may disappear after exercise, because ischemia produce ST depression. If ischemia improved by opening of collaterals, then it can disappear. That is the, I think, this is the explanation I have seen.
These phenomena are not commonly observed in ETT. Rather, these phenomena and explanation are more applicable in MPI.
May I ask one question? Actually, sometimes patient developed ST depression, and in the recovery phase, there is rapid changes of ST depression to normal. So it is sometimes we get the patient, and actually typical sometimes we write suggestive of ischemia, sometimes we write typical of ischemia. If it does persist more than 3 minutes, then we usually write typical of ischemia. Is there any differences, or it is justified?
As I have got a chance, I like to add one important point, that sometimes some physician only look at the screen and the tracing and the what computer says. Mind it, when there is significant artifacts, computer make an average. In GE machine, this is noted as linked median or linked average. And in those cases, there is significant ST depression is marked and just presented, though that is not really ST segment depression. In these cases, if you just take a tracing within 15 seconds of stopping exercise, that may be very valuable for interpreting whether this is true positive or not.
Thank you, Dr. Kaisar Rasulullah Khan.
Assalamu alaikum and good evening to all. Wonderful and brilliant lecture in Monwarul. I always wanted to be his student, and today my dream came true. Alhamdulillah. I would like to thank also IPDI for arranging this continuous medical education. Having said that, my take from this lecture is that we should all be able to know about a very important and low-cost tool to evaluate coronary artery disease. And what Wadud Bhai said, if a patient is having class 3-4 angina, or sometimes I see that resting ECG showing ST depression or very prominent ST changes, then I think referring that patient for ETT could be disastrous, could be catastrophic. It might culminate into heart attack, which Monwarul also did. So we should be very careful while we're referring a patient for ETT. And secondly, which is come out from the discussion, which is not relevant to ETT, but I think this section should get more important in our country now. That is post-MI rehab, and there also this treadmill has got a very, very important role. Thank you.
We are happy to announce that Dr. Khalid Mohsin sir will talk on cardiac evaluation next month. Dr. Professor Khalid Mohsin sir will talk on cardiac evaluation. Dr. Kamrul Bhai, Dr. SM Kamrul from Khulna, Dr. Kamrul Haq. Kamrul Haq. Yeah.
Kamrul Bhai?
Yes. Hello?
Yes.
Colin.
Yes. প্রথমে আমি আমার স্নেহভাজন ছোট ভাই মনোহরকে ধন্যবাদ জানাচ্ছি, একটা চমৎকার সময় উপযোগী এবং খুবই প্র্যাকটিক্যাল একটা প্রেজেন্টেশন করার জন্য, যেটা অনেক বই পুস্তক পড়েও আমরা এত অল্প সময়ে যা শিখেছি সেটা শেখা সম্ভব না। আর এই লেকচারটা যে আয়োজন করেছে IPDI, তাকেও ধন্যবাদ জানাচ্ছি, তাদের বিশেষ করে প্রফেসর আব্দুল ওয়াদুদ চৌধুরী এবং স্নেহভাজন ডক্টর মহসিনকে, যেটা সময় উপযোগী এবং ভেরি ডিমান্ডিং টপিকস, not only for the fellows or postgraduate students, also for the clinician and cardiologist too. তো এই টেস্টে অনেক লিমিটেশনও আছে, তারপরেও এটা অনেক ইউজফুল টেস্ট। লিমিটেশন গুলো ডক্টর মনোহর বলেছেন, বিশেষ করে ফিমেল পেশেন্টকে এটার ফলস নেগেটিভিটি ইনসিডেন্সটা কম না, 15 to 30% কেসে একটা ফলস নেগেটিভিটি শো করে। সেসব ক্ষেত্রে আমাদের অনেক সময় ফিমেল রোগীদের ইটিটি ইন্টারপ্রিটেশনে প্রবলেম ফেস করতে হয় যে আমরা কি লিখবো, সেটা ফলস পজিটিভ আর ফলস নেগেটিভ। এ ব্যাপারে আমি ডক্টর মনোহরের দৃষ্টি আকর্ষণ করছি কিছু বলার জন্য।
Actually, ETT probably plays less efficiently in case of females. But if we apply the Diamond-Forrester risk assessment tool and select the appropriate ladies for ETT, in those cases, ETT may not be so unyielding. Number one. Number two, in some cases like these ones, if I am in doubt, I rather advise CT coronary angiography.
Thank you. Khaliduzzaman.
Thank you. Thank you.
Thank you. অনেক রাত হয়ে গেছে, বেশি ডিসকাশনে না যাওয়া মনে ভালো হবে, কিন্তু আমার একটা হচ্ছে যে in this COVID era, is there any change in recommendation of the exercise tolerance test in the diagnosis of coronary artery disease? Does the CT angiogram coming up as parallel as ETT for diagnosis of the coronary artery disease? And what is the latest recommendation, guidance recommendation by European Society of Cardiology? Will you put some comment?
Very time demanding
yes,
question.
sir, this is a very time demanding question. Actually, in presence of COVID-19 era, especially those centers or hospitals dealing with COVID patients, ETT is generally should be avoided because there is high chance of aerosolization and contamination.
Thank you.
And here comes the beauty of coronary angiography.
Thank you.
Yes.
Thank you very much. Thank you.
Actually,
question more than 2 hours time. Just we just clock is 12 o'clock midnight, so we should conclude our session. Thank you all the panelists, all the faculties here, all the participants being with us at the midnight, especially Dr. Monwarul. You are our jewel. Congratulate you from a cardiologist, also IPDI. That's part of IPDI. Thank Inceptor Pharmaceuticals. They are doing a tremendous job last 1 year. Being at the midnight, there are lots of troubles, pain from the IPDI. Thank IPDI, Dr. Mizan, Mr. Mizan and Inceptor team. Thanks everybody. Also, sir, please conclude your session.
Thank you, everybody. We do have a very beautiful session, very interactive session. Important issues. I think there will be many more questions. I will ask the audience to put your questions into the IPDI virtual classroom chat box. So we can discuss again these issues in another day. So it will be very helpful for everybody.
Dr. Wadud. Mohsin, can I ask one question?
Yes.
Yes. I partially missed the Monwarul presentation, but I enjoyed the discussion. I asked to Monwarul one question. After ETT positive, we found sometime in cath lab severe left main disease. Whether these topics have been discussed by Monwarul or not, I like to expect some comment about this finding. How we can avoid the just ETT positive, but when we did in angiogram, there is severe left main disease. এই রোগীগুলোর কি ফেট হতো, আর একটু যদি ইটিটি পজিটিভ করতে যেত তাহলে তো কার্ডিয়াক অ্যারেস্ট হতো। আমরা কি আগে থাকতে প্রেডিক্ট করতে পারবো যে এইগুলা ইটিটি করা ঠিক না, লেফট মেন্ট হতে পারে?
Thank you, sir. The most important thing is that we have to
stage 2 তে left hand disease হয়, stage 2 তে পজিটিভ, মাইল্ড পজিটিভ, কিন্তু লেফট হ্যান্ড ডিজিজ পেয়েছি অনেক, তখন কিভাবে আমরা এটা?
Sir, we have to pay due attention to what patient says. This is very important. Number one. Number two, if some patient develops positive or widespread ST segment depression or ST segment elevation in some leads, in that case, in lower workload, minded stage 1, we have to be very cautious, because in that case, the patient may have left main or maybe triple vessel disease. We have to be very, very cautious. With these ETT reports, we have to be very cautious regarding coronary angiography as well. Even in that case, you can perform some sort of non-selective angiogram at first. You may give some dye at the root of the aorta to be sure or whether there is.
Thank you, Monwarul.
Dr. Monwarul, importance of AVR in interpretation of ECG, particularly ST elevation.
Stop it, because it's already midnight. And
sorry.
I'll be asking everybody to write your questions and put those questions into our IPD virtual classroom chat box so that we can arrange another discussion about the whole thing. I think I have to thank everyone, and principally Dr. Monwarul Islam for his beautiful lecture, and also the Incepta group, because they are working so hard for making all these things a success. Thank you, everybody. Good night, and we'll see you again.
Good night, sir.
Thank you, sir.
Our next class is Stress Eco by Dr. Mohammed Lafiroj. Stress Eco. See you on 19th March, Friday, at the same time at 10 p.m. We are enjoy Dr. Firoz's class. Dr. Monwarul, thank you. Thank you.
Thank you,
Manoj bhai, for brilliant lecture. Good night. Good night.
Kamrul bhai,
thank you everybody. সবাই ভালো থাকেন.
Ajoy, thank you.
অজয় ভাই, thank you. ভালো থাকেন.
Good night.
Night.